The next individual we have speaking for our keynote today is Dr. Michael Grandner. He's at the University of Arizona, clinical psychologist and director of behavioral sleep medicine. He's joining us today. We're happy to have him here to talk about some of the links between insomnia and suicide. Yes, sleep disorders and suicide, sorry. All right, I'll let Dr. Grandner take over. Thank you.
All right. Thank you very much. So, thanks. And I didn't even say anything yet. All right, so I think this is a very important topic. It's a very important issue. And I want to make sure that I preface this by saying, it's a very positive event, and suicide can be difficult to talk about, but I think it's really important for a few reasons. Some things you may or may not know. A suicide occurs in the US about every 12 minutes. The suicide rate in the US has risen by 33% since 1999. Suicide is the second leading cause of death for ages 10 to 34, according to the most recent CDC data. And it's the fourth leading cause of death for ages 35 to 44. It's the leading cause of death in military service members. It beat out warfighting. I think it was around 2012 when it took the lead. Over half of suicides show no record of known mental illness. And suicides are rising faster among women than men, even though more men commit suicide than women. So here's a time-lapse image of suicide rates by county in the US, showing that this is increasing prevalence. Let's see. Sure. I can't. It's just, it goes on its own. But you could find it, Google it, you'll find it. It's estimated that for every suicide, there are about 29 attempts. Suicide rates in men are about 3.5 times that of women, but women attempt suicide about 40% more often than men do. White men account for about 70% of all suicides, especially middle-aged white men. The next highest demographic group is American Indians. Firearms account for more than half of suicides. So these are some really important statistics. And about one, and especially this one, this is the one I wanted to draw attention to, about 1 in 167 adults has made at least one suicide attempt. That seems like a relatively low number, but how many people are in this room? 167 is not that many people. So when you study suicide from a scientific perspective, it's kind of hard. One way that we look at it is looking at ideation. So this is the term for people thinking about suicide. A lot of ideation is actually quite common in the population, at least at some point. It doesn't mean someone's going to attempt suicide, but it's still an important risk marker. Then you have attempts. Attempts are much harder to study because they're a much more rare event, but they're more serious. And then you have actual deaths by suicide. So these are three different things that we're looking at. And I'll preface this by saying all of them have been shown to be related to sleep problems. So some well-known suicide risk factors are serious physical health conditions, especially pain that's not going to go away, especially intense pain. Mental health conditions, especially depression and substance use disorders, as well as serious mental illness, things like schizophrenia. Feelings of hopelessness, feeling trapped, and being a burden to others, major risk factors for suicide. Traumatic brain injury. Stressful life events like a divorce or a major rejection or a financial crisis. These are all major risk factors. Being exposed to suicide is a risk factor for suicide. Knowing somebody who committed suicide or even hearing about it. And access to means, including firearms. So what's the role of sleep health here? Sleep is related to injury, illness, and pain. Sleep is related to financial hardship. Sleep is an important factor in mental illness. Sleep disturbance is a key factor in substance use, and it plays important roles in emotion regulation and mood. Sleep plays important roles in decision-making as well, which I think is a very important part of this process. So when you think about all of the major risk factors for suicide, sleep plays important roles in all of those. So it shouldn't be that surprising that sleep is related to suicide. So having a major illness, especially one that's debilitating and or degenerative, is a major suicide risk factor. Also extreme pain. Most major medical conditions, especially those that are degenerative, are associated with poor sleep. Sleep loss increases pain perception, sensations of pain, and impact associated with pain sensations. So here's an example. Robin Williams, very famous suicide case. Here was a paper published in Neurology, an editorial written by his wife, explaining the context. A lot of people talk about it as a depression issue. At least from her words, it wasn't a depression issue. It was an issue of neurodegenerative illness. This was a Lewy body disease that was documented as being very rapid and very debilitating. Financial hardship. So poor sleep is associated with lower household income, increased likelihood of poverty. Here's some of our data showing that as your household income goes up, your likelihood of getting insufficient sleep decreases. Also associated with housing-related financial stress and food insecurity. So people who are under more stress to be able to afford housing and to be able to afford food also sleep worse. And it's also been shown that this sleep problem is part of the link between these and other bad outcomes. Lack of sleep is also associated with unemployment and suboptimal living conditions, looking at noise and other environmental problems. So here's some data looking at suicide rate relative to unemployment rate, showing a pretty strong correlation. Here's another important study that looked at suicide ideation relative to socioeconomics, and it was about a change in your socioeconomics based on where you thought you should be. And the bigger the difference between where you were and where you felt you needed to be, the higher level of suicide risk. A little bit on sleep and mental illness. Many of you probably have heard a lot of this already, but sleep disturbances are described as a core feature of pretty much every mental illness in the book, whether it's depression or bipolar disorder, anxiety disorders, especially PTSD, which was also associated with high suicide risk, major mental illnesses such as schizophrenia, attention deficit disorders, and more. So pretty much any major mental illness has sleep problems as a core feature. So the relationship between insomnia in particular and depression is one of the most well-established findings in sleep research. Poor sleep quality is associated with every single symptom of depression. So here's some data that with words really too small that you can't read. From a study we published this year showing that if you go to every single symptom of depression, whether it's loss of interest, whether it's psychomotor slowing, whether it's appetite dysregulation, every single one of those was associated with one of the core features of insomnia, even if they might have been different ones. For example, some of the emotional ones were associated with some of the daytime consequences of insomnia, where some of the more physiologic ones were associated with the lack of sleep itself. But taken together, this experience of not being able to sleep is associated with pretty much every factor in depression, including suicide ideation, which is on that list. Insomnia predicts the onset of depressive episodes and their recurrence better than depressed mood does. So here's an example, it's probably hard to read graph, but it's an older study, you can't fault them for that. But one thing you can see is across the bottom here is every single item on the Beck Depression Inventory. That we're tracking people with a history of depressive disorder for weeks and weeks and weeks until they recurred with a new episode of depression. That's that end where it says recurrence. And then they counted back 4 weeks and they plotted their scores on every single item to see what happened. And one thing you can see here, even if the words are too small, you can see there's one of the items that rises first, rises fastest, and rises most persistently. And that wasn't depressed mood, that was sleep disturbance. And then when they looked in the same people at a 4-week period that didn't end in a recurrence versus one that did, insomnia didn't get worse. So insomnia only got worse when depression was coming back. And this is a pattern that you see in a lot of recurrent illnesses, whether it's depression, bipolar disorder, and even cancer. That when you see a recurrence of insomnia for no apparent reason, but your sleep is getting worse, it's an important warning sign. Sleep is very much a canary in the coal mine. A recent meta-analysis where they took every study that was published that linked some aspect of sleep and suicide showed that insomnia was associated with about a 3-fold likelihood of thinking about suicide, about 3.5-fold likelihood of actually attempting suicide, and about a 2.5-fold likelihood of actually dying by suicide. So it was proportional. Even though attempts are more rare and deaths by suicide are still more rare, the degree of risk attributed by sleep was parallel across all these outcomes, which shows that sleep isn't just about thinking about suicide, it's also important in the outcomes as well. There is some data showing that you can treat this insomnia with CBTI and it might actually reduce some of the suicide ideation, but this is still a very new idea. Here's some data from our program where we showed that even young adults, these were college students, and the degree to which they had sleep difficulties for the past year, and specifically insomnia, was associated with an increased likelihood of thinking about suicide, because that was what we were able to measure. Even after adjusting for covariates, that did nothing. And even throwing mood into the predictive model, controlling for whatever depressed mood they had, sleep difficulties were still associated with a tripling of the likelihood of suicide ideation and a doubling of the likelihood in the case of insomnia. In young adults, each additional night of insufficient sleep was associated with increased risk of suicide ideation, even after adjusting for depressed mood, which is the yellow bar. It took some of the effect out, but there was still a lot left, even after depressed mood. So here's some population level data showing that both short and long sleepers, on average, are more likely to be thinking about suicide. Nightmares are another important risk factor. Frequent nightmares are associated with depression, anxiety disorders, especially PTSD, and the presence of nightmares, similar to insomnia and similar to insufficient sleep, similar to sleep difficulties, you're looking at about a threefold increased risk of suicide-related outcomes. So it almost doesn't matter which aspect of sleep you're looking at, you're going to see this increased risk. So here's some data on suicide-related outcomes in people with nightmares versus without. And you can see it's higher in the group with. There's some data on sleep apnea and suicide risk similarly, that having disturbances in sleep is associated with increased suicide ideation, suicide planning, and even attempts. The attempts relationship after controlling for covariates wasn't significant, but again, that was a more rare event, so it was harder to detect. Even in the general population, without sleep disorders, problems with sleeping are associated with increased suicide risk, even after adjusting for depressed mood. So again, it's not just about sleep and depression. Sleep itself is doing something. It might even be better than depression. So here's a study showing that insomnia symptoms predicted suicide-related outcomes even after controlling for depression, and even better than depression 1 month later, looking at the change. So why? So we have a paper that some colleagues and I published where we've been thinking about this, where we notice in insomnia patients, they get very distressed, especially when they're up in the middle of the night. They catastrophize, they blow things out of proportion. People get very emotionally dysregulated in the middle of the night. And this happens with sleep apnea patients too that we see in clinic, is this idea of being awake, just being awake at night when your body wants to be asleep might be a bad thing. So how do we answer this question? So one thing we did is we got access to the CDC data, which tracked pretty much every suicide across the 19 states that they were able to gather data for about a 10-year period that we looked at. And what we wanted to do is we wanted to see, did suicides happen more likely at night? If being awake at night is a bad thing, right, you'd expect there to be more suicides at night. So what did we find? Overall, what we found was Not bad. You can see this was the proportion of suicides across the 24-hour day. And you can see the peak is around noon, and the bottom is like 3 or 4 in the morning. So I'm like, oh well, there goes that. We're looking at this, and in the meantime, we'd actually found a couple of other studies that ended up looking at this. So here's some examples of them. So here's one study that showed same thing, suicides were low in the middle of the night, high in the middle of the day. So here's another study that showed suicides were higher in the early part of the day, and they dropped across the day, and they were lowest at night. Here's another study from Italy showing suicides lower in the middle of the night, peaking here during the day. They all found sort of the same thing. So we're like, well, at least what we found was consistent. But we looked at the data, and we thought, we're missing something. And so we sat there and we're thinking about it, and eventually we realized what we had gotten wrong, and all those other studies, there were like 7 or 8 other studies that were done, those are just 3 of them, they'd all gotten wrong, including us. And that was, to be able to commit suicide, you have to be conscious. And like if you're walking on a city street, and there's 1 million other people on the street with you at noon, and 1,000 of those people want to do you harm, right? So there's 1,000 people out to get you in the middle of the day, but that's 0.1%, 1,000 out of 1 million, right? That's 0.1% of the people that are out there. But if you're walking down that same city street at midnight, 12 hours later, and there's 100 people out on the street with you, and 10 of them want to do you harm, that's actually 10%, even though 10 is a lot less than 1,000. So the number of people out during the day that are dangerous are higher. So the number of crimes that are going to happen is going to be higher during the day because there's more people, 1,000 versus 10. But actually the danger is greater at night. And when we wrapped our head around that, we realized all hours aren't equal. We need to weight them by who's awake. So actually we had this idea, and we came up with the solution of looking at some data from the Bureau of Labor Statistics that collects data on 24-hour patterns of who's at work, but they also looked at 24-hour patterns and who's in bed and who's not in bed. And so one of our colleagues had these data, computed all of the averages by each age group for each year we were looking at to get a value of what proportion of the US population is actually probably awake at each given hour. And we used that proportion to weight the numbers. And so we filtered out the signal of wakefulness, because that signal, that was not the suicide risk signal. That was the consciousness, wakefulness, population signal. So when we filtered out that signal, what we found was that nearly all of the increased risk was actually at night. Here's the data. That's what it ended up looking like. And so when we saw that, that was striking. I mean, you usually don't see a peak like that that's that obvious. And so that's what we were looking for. The danger for suicide is actually dramatically greater at night, peaking like 2 or 3 in the morning. So then when we just statistically compared nighttime versus all the other times, don't need to read all these numbers, but basically what this is showing is it's off the charts higher at night versus morning, versus afternoon, versus evening. It was present in men and women. It was present in people who were white, black, Hispanic, Asian, or other. It was present in every age group. It was there. Some age groups, in younger people it was stronger, for example, but it was statistically significant, strongly so, in every age group, in pretty much every demographic group. It didn't matter who you were. So we followed that up also. So one question is, well, if it's about the night, doesn't the night change across the year? So let's look by season. And so what we found was, so these lines at the bottom, that's the seasonal pattern of suicide risk during the morning, afternoon, and evening. They're like all right on top of each other. The purple bar on the top, that's the night. Again, elevated at night for every single month. It looks like there might be peaks in May and October, but those weren't statistically significant. So on average, it looks like the length of the night isn't what matters. Then we looked at the mode of suicide. So you have firearms, you have as the most common, and you have the other modes of suicide. Again, there was no statistically significant difference between any of these. but they were all different from the other times of day. You can see all the other times of day, all there at the bottom, sleep is at night is elevated. And what this goes to show is our interpretation of this is that being awake at night influences your decision of what to do, but not necessarily how to do it. It's not that certain things are more available at night. Clearly they're not. It's the decision that happens. So this idea of thinking at night, we're asking right now, I've got a grant going in next week to try and look at this, what are the mechanisms underlying this relationship? Why? Why is it that being awake in the middle of the night is associated with suicide risk? And this is something that our hypothesis is, this is what's unifying. This is why the risk associated with any sleep problem is very similar. It's because they all have this in common. That they're increasing this wakefulness at night when you're not thinking well and when you're emotionally dysregulated. Like how many people in this room, just think about it, when you wake up at 2 or 3 or 4 in the morning, how many times are you waking up calm and relaxed and pleasant? Like no, it's usually panicked of some sort, worrying about something, and feeling like there's nothing you can do, especially if it's the middle of the night and everyone's asleep and everything's closed and there's nothing you can do. And we think this is a normal process. This is just what brains do in the middle of the night. It's just when you're repeatedly exposed to this, it might increase your risk for making a decision like this. So how can this help us prevent suicide at a population level? Like what if we understood how these processes worked and got a better handle on this idea of being awake in the middle of the night itself as a risk? Can we improve our suicide risk detection and prevention? Because right now, we're not doing very great as a population about this. If anything, the problem's getting worse. So how can this better help us treat conditions? So all of these conditions that are associated with increased suicide risk, especially injury and pain and mental illness, involve a lot of this wakefulness at night. So is there a way that we can reduce suicide risk by treating this? And so you know, we have this paper where we laid out some of these ideas about where to go from here, but this idea of surviving the long night, you know, when you're up during the night and it's an excruciating process, what is that doing? And I really want to push home this idea that suicide is a major problem. Sleep is also a major problem. Not everyone who's sleep deprived has suicide risk. But there's an overlap. It's systematic, it's reliable, and it almost doesn't even depend what kind of sleep problem you have, whether it's sleep apnea or insomnia, or just you're waking up during the night. And so with that, on that note, no, thank you, and thank you for your attention on this issue. I think this is an issue of great public health importance, and I appreciate you thinking about this and seeing what you can go home and do to help with this. So thanks.
Questions from the audience. I just wanted to point out we're literally looking out at the Robin Williams Tunnel and the Golden Gate Bridge, which is probably, if I'm not mistaken, the #1 suicide spot in the U.S., if not the world. Any questions? I know it's not a very fun subject to discuss after lunch, and we will get to a more uplifting theme, but we definitely need to have this conversation because no one else will.
Fascinating information, and I was aware that there was increased risk of depression, and we know that Ron Harper at UCLA showed the actual damage to the brain with diffusion tensor imaging. That is areas of the brain that are linked to depression, and we can actually see that. So I was really interested in learning now. You did mention that maybe people are awakening and then committing suicide. Do you have any evidence, any data that shows that versus they have yet to fall asleep and then commit suicide? Because then obviously one treatment might be
exactly
medical treatments to keep them asleep, is doxepin or something or what have you.
Yeah, so the first answer to the question is that's why in the grant we have 2 conditions of people being kept up and then being tested versus being allowed to sleep and then woken up and being tested, because it's an open question. When you look at the evidence, a lot of it is retrospective. So, and when we know when the deaths occurred, no one asked were they awake or were they asleep. So a lot of that information isn't there. The most you can get is, so there's one study in particular looking at internet searches and like what time those are happening and what are they searching for, and are they searching for suicide related things related to sleep. There's actually some interesting data on that. But yeah, no, that is a very good question. One of those questions is, to what degree is this circadian? To what degree does the circadian factor get modified by sleep pressure and sleep debt built over a night or over a year? I think this is an open question right now. I think just showing that when you talk about suicide, talking about sleep as one of the important risk factors, I think we just got to that point. But you're right, that's one of the next questions.
Excellent contribution to the field. Thank you.
Thanks.
Here, we have another question over here.
Hi, an excellent talk, and there's no question that I can tell you from my own world that sleep apnea exacerbates the problem that you're seeing and makes it worse. It seems like though you're kind of avoiding in the sense the 800-pound gorilla that was there, and I hate to drag politics in the room, but I'm gonna.
Yeah.
It's going up, suicide's going up. Gun violence is going up.
Yep.
Substance abuse is going up. These are mental health problems. And mental health problems are what you're seeing are stress problems, sleeplessness. So we are unquestionably a stressed out society and becoming more and more stressed out. This is what happens when you have massive wealth inequality, a whole sector of the population that can't make it, and stress. And this is an economy that is broken and has been broken for a long time, and that's what you're seeing in your data. So I guess my only words to everybody is go vote.
Right. And that's also why I wanted to point out. That's why I wanted to point out that sleep is universal. Like, sleep is a biological requirement for human life, like air, water, food, and that's probably it. And our society, though, does not see it that way. Our society has sort of forgotten that. You never hear people say, when I retire, I'm going to think about getting clean air. Some people do, I guess, but we don't see that as a good thing, right? No one says, clean water is a luxury for people with too much free time, And it's because our society values productivity to the point of absurdity, where sleep is seen as an enemy to productivity. That's actually sort of why some of the work that we're doing is actually showing that if you sleep less, you are actually less productive. So don't do that. Because, we talk a lot about health. We talk about, we could show sleep in obesity, sleep in blood pressure, sleep in diabetes. And when you go out into the real world, people are like, well, if I cared about my blood pressure, I'd take my blood pressure medication, but I don't. And so sleeping more is not on the list of things I'm going to do. But if you say, look, it'll help you lose weight, it'll help you earn more money, actually things that you care about, maybe we can reach people because I think you're right. We live in this world that's set up for us to fail when it comes to our health and our behavior. And one of the things we need to do is make some of these fundamental changes. And I would say part of that is fundamentally changing how we see some of these things. But yeah, sleep is related to financial hardship, and it's related to stress, and it's part of that, totally. You had a question.
Two different comments. On your list of factors that go into insomnia and possible suicide, there was this long list of pain, health, anxiety. What happens to those of us who don't have any of those?
Right.
And still have insomnia and still have, and are not necessarily moving in the direction of a mental illness or whatever? Has your study done anything in that line?
So that's a good question. That's actually where this was going, this idea of it actually doesn't matter what brings you to the point of being awake in the middle of the night. Or maybe it does. But the fact that pain contributes and depression plays a role, those are issues in addition to this idea that sleep itself, keeping you asleep when you're supposed to be asleep, does something to protect you from the sorts of thoughts and decisions and behaviors that will put you at risk, whether or not you're in pain. And that's something that I presented it sort of subtly here, but I think that's kind of a new idea that I think we had, that I don't know that other people are talking about it this way, where it's not that you're in pain and then have insomnia and the pain is the suicide risk factor, or even that it's the insomnia. It's the fact that you're repeatedly exposed to this idea of you're awake when your brain's also not totally awake and you're not thinking well, whatever brought you there. So I think that's an important reminder that you have, that you sort of give to the room, that it's not just about these risk factors. Yes, they're the risk factors and they're related to sleep too, by the way, but they all lead to this place. And that place itself is a bad place, no matter how you got there. So I agree.
Okay, follow-up. On
Yes.
one of your slides, you had a slide about the treatment through CBDTI.
CBTI, yeah.
So let's talk about that a little bit.
Yes.
We are in San Francisco. Let's not ignore the elephant in the room here again. And would you discuss, has it research that's done it? And because you just flashed through that slide.
Okay, yeah.
And I think we need to hear a little bit more about that.
So CBTI is a way of treating insomnia without medications that mostly involves retraining the brain to sleep when it sort of forgets how to sleep. So this is people who get into bed and their mind is going and they can't wind down, or they're trying to sleep and they can't. And the idea is that over time, the ability of the act of trying to fall asleep to actually put you to sleep becomes diluted, and you can't fall asleep when you want to. And what CBTI is, it's a therapy that's a collection of techniques that help essentially reteach you to sleep. With patients, I explain to them, it has the word therapy in it, but it's a lot less like psychotherapy and a lot more like physical therapy. It's a learning process. And what a lot of people don't realize is it's actually the recommended first-line treatment for insomnia. Even the American College of Physicians, the main internal medicine organization, the one that does the prescribing of sleeping medication, their official guidelines are, look, if you've got insomnia as an adult, you should be getting CBTI. Forget medication, don't even try medications first. CBTI is the recommended first-line approach if you have access to it, if you can get a referral or whatever. The evidence is there, it's been there for decades. Not only does it work shockingly well, but when you compare it head-to-head against medications, it tends to work as well or better, actually, in the same time frame, the same 8-week period, and it tends to beat it pretty well long-term, which is why it's the recommended approach. But a lot of people don't know about it. And they think it's like sleep tips, like, yes, cutting out caffeine and blackout curtains and putting your screen down. Those are all good, but that's not behavior therapy. There's actually therapies involved. And San Francisco is a great place for it because there's a lot of people, I don't know about a lot, but there's people here. There's not a lot of cities that have multiple people who do it, but San Francisco is one of them. You can get CBTI in San Francisco if you go looking for it. So thanks for giving me the opportunity to soapbox on that.
So I'm curious about the date, and it just might be when you're looking at the data, but sort of agree with culturally with the U.S. Yes, it's all about productive. That makes my self-worth.
Yeah.
But we've had that culture for a really long time.
Yeah.
But I'm struck by the 1999.
Yeah.
As a person who worked in industry, in the corporate world, with and without the technology that does not stop.
Yeah.
Did you see that in the data in terms of the correlation either in suicide rates or sleep issues related to the fact that we can be 24/7 connected and working, literally never stopping?
Yeah, I mean, I think that's pretty obvious. Like, technology has done many great things. But like everything good, it has another side. And this idea of constantly being connected, when you look at the relationship between technology and sleep, there's two main things that people end up talking about. One is the light itself, because the light itself hits the eye, travels to the hypothalamus, and sends a signal that suppresses melatonin, which might make it harder to sleep. The other piece that gets a little bit less attention, but might actually be stronger if you look at the data, is the idea of the mental activation caused by these devices, where you're on them and you lose sense of the passage of time. And that interferes with sleep. It makes it harder for you to tell when you're ready to sleep. It makes it harder for you to respond to your body's own signals. And even if you don't have that, you have this mental activation that you then have to relax from. And even if you don't have that, a lot of times people think that they're watching TV or watching videos or whatever as a form of relaxation. And people don't know the difference between relaxing and distracting. Those are two very different things. They're both useful therapeutically, but they're different. Distraction presses pause. And then as soon as you turn the TV off, you're back again and your mind starts going. Relaxation is an active process. That's an active process of, it's like exercise. You don't just exercise passively, you have to do something. Same thing with relaxing, you have to do something mentally or physically. And so that's why technology has this thing. But there's another dimension that doesn't get talked about as much, and it's something that you alluded to, is the anxiety issue. So for example, just yesterday, we're working on analyzing some of the data we've collected on mobile phone use and sleep in a population sample. So we're going to be writing this up for the sleep meeting. It's not published yet, but we just ran the first pass of the analyses. But one of the things we found was the relationship between mobile phone use at night and performance deficits during the day. It seems like the idea of your anxiety around that, it seems to be a primary pass. This idea of needing to be looking at things. And the idea of being unable to let go itself might be a whole other dimension besides the mental activation itself and the light itself, our attachment to the device and our fear of not having it or the fear of not responding to something, that itself might be causing problems. And so if we are going to leverage technology to get as many of the benefits with as few of the drawbacks, I think we're in San Francisco, so if anyone's listening, if we could find a way to not have technology be the enemy, but not have it make things worse by having ways to help it wind down, ways to help you disconnect a little more and have it be okay. And when I talk to HR departments, so when I talk to workplaces, a lot of times they'll say, okay, I'm on board. What can I as a workplace do? The first thing I say is, don't encourage, even subtly, the idea of sending emails in the middle of the night or first thing in the morning means you're a good worker, or that you're responsible, or that you're responsive, or that you have a good work ethic, or that showing up first thing in the morning at 7:30 and leaving late somehow means you're a better worker. Time on task does not equal productivity. And people forget that, or they don't trust people, and at least that's one thing they can measure. But if you actually want to protect your workers' health and productivity, actually maybe that's not your metric. Your metric should be based on outcomes, not on were you sitting in front of your screen first thing in the morning or last thing at night. So I think you're exactly right, and I think that's where we need to go.
Thank you, Dr. Grandner.
Thanks.
I think we could spend a week talking about this.
and I'll be here the rest of the day, so we can talk more. All right. Thank you very much.